Hello, and welcome everyone to the Peggy Lillis Foundation's 2024 State of C. diff Virtual Town Hall. I'm Christian John Lillis. I'm the co-founder and CEO of the Peggy Lillis Foundation. Many of you may know that we started the foundation after losing my mom, Peggy, to a community-acquired C. diff infection in April of 2010. And over the years, we've done a lot of different things to raise awareness and educate folks who are battling C. diff or a family member battling C. diff. But the State of C. diff Town Hall is one of my favorites because we get to bring truly amazing experts who are coming to speak to an audience that is largely C. diff survivors, patients, and family members, to give you an update on what's happening in treatment, policy, etc. So I'm very excited to be doing this, and we have had an amazing C. diff awareness month so far. We kicked off on November 1st by having our annual C. diff, we kicked off our annual C. diff awareness campaign on November 1st. This year, our theme is diagnosis. So if you're not following us on social media, do go ahead and check us out on social media and share our content to help us raise awareness. And then on November 8th, we had our 15th annual gala. And we recognized and honored 3 incredible women who are really making a huge difference in C. diff, including Dr. Denise Cardo, Marianne Webb, and Dr. Jessica Allegretti. It was super fun. And last Friday, we held our first ever scientific symposium, where we had every leader, every clinical and scientific leader in C. diff, I think, presented that day. And it was truly, truly wonderful. So we're going to keep it rolling. So tonight we are here doing our 2024 town hall. We're going to hear from some really incredible people tonight. I'm going to come back and introduce each of them. Sorry, I'm just getting my thing lined up. So tonight we're going to hear, in addition to myself, from 4 excellent speakers. We're going to hear about C. diff diagnosis and treatment, new and upcoming treatments, the impact of social and economic vulnerabilities on CDI outcomes. One of our board members is going to share her experience doing advocacy and peer support this year. And then I will talk about sort of the state of C. diff policy towards the end. So like regulations, laws, some stuff that we've been up to and what we're going to look to do next year. And to make sure we stay on time, we're going to ask that you hold questions till the end. So if you have questions, you feel free to write them in the chat. We're going to monitor that, but we're going to let everybody do their presentation. And then at the end, we'll come back and answer any questions. So also stick with us for the whole time, right? So I really want to thank Nestle Health Sciences for sponsoring this town hall for the 2nd year. They are truly an amazing partner, and we enjoy working with them immensely. And on that note, before we move into the science, medicine, advocacy, and policy of it all, I am delighted to introduce Kate Dougherty, who's the Director of Brand Marketing for Nestle Health Science, and she is going to provide a welcome from Nestle to everyone at the town hall.
Thank you, Christian. On behalf of Nestle Health Science, welcome to everyone joining this Peggy Lillis Foundation State of C. diff virtual town hall. It is an honor to kick off this meeting and to join a very important discussion. I'd also like to express our gratitude to the Peggy Lillis Foundation for organizing this event. The work that you do in raising awareness around C. diff and advocating on behalf of patients is as important as ever. We are proud to support your efforts in improving the lives of those affected by this serious condition. Nestle Health Science is in a unique position with a diverse product portfolio spanning consumer, medical nutrition, and pharmaceuticals. In particular, we leverage the expertise of our entire organization's deep understanding of the GI system to develop and commercialize innovative products that help address the specific unmet needs of patients. Today's town hall provides us all with a valuable platform to share knowledge, exchange ideas, and discuss the latest advancements for patients and healthcare providers. I would like to express my sincere appreciation to all of the healthcare professionals, researchers, and advocates who are dedicated to improving the lives of patients with C. diff. Your passion and commitment are truly inspiring, and we are honored to be part of this community. Thanks again to the Peggy Lillis Foundation for organizing this virtual town hall and for giving us the opportunity to be a part of this important conversation. Together, we can make a difference in the lives of those most affected. Thank you, Christian.
Thank you so much, Kate. I was joking earlier with Kate that she was the first person in a while that I've met in person before seeing her virtually. So that was exciting. She was at our gala last week. So now for our first real topic here. I am very pleased to introduce a woman who is quickly becoming one of my favorite doctors to partner with. Don't tell the others who might be listening. But Dr. Stacy Kahn is an associate professor of pediatrics at Harvard Medical School. She's also the director of the Fecal Microbiota Transplant Center and an attending physician at Boston Children's Hospital. Dr. Kahn performed the first colonoscopic, God, I should have practiced that word, fecal microbiota transplant in a child, and has led the development of the first national pediatric FMT registry. We've had the chance to work together closely several times this year, and I can say without hesitation that Stacy is a brilliant clinician and scientist, and she really fights for her patients. So please welcome Dr. Stacy Kahn. She is going to present on C. diff diagnosis and treatment.
Thank you so much, Christian, and thank you to the Peggy Lillis Foundation for inviting me to speak at tonight's town hall. As Christian said, I'm incredibly passionate about the care of children, and particularly children and young adults with C. difficile. And tonight I'm going to share with you probably some information that you're familiar with, as many of you have experienced C. diff firsthand, either as care providers, loved ones of individuals who've been affected, and actual survivors of C. diff. And I hope that you'll come away with some ideas about some of the important work that needs to be done in this field. These are my disclosures. So as you all may be very well aware, Clostridioides difficile, or C. difficile, or C. diff as it's commonly caused, is a bacteria. And it is a really tricky bacteria, as the name implies. It falls under the classification of a gram-positive anaerobic spore-forming bacillus, which is describing how it likes to live in conditions without oxygen, and that it makes two forms: a spore, which is not the live bacteria, but is responsible for the transmission of this very significant infection. It produces two toxins which cause the symptoms. And those symptoms can range from being asymptomatic and having C. diff in your body and not knowing it, not having any effects, to severe colitis. And that can present with abdominal pain, urgency, bloody diarrhea, fever, dehydration. And our most severe cases, it can lead to fulminant, life-threatening colitis with sepsis. And as shown in this picture, and I hope it's not too graphic for the members of the audience, this is a picture of what megacolon looks like, where the bowel is essentially paralyzed and stretched to its absolute maximum. And it's really a very severe life-threatening emergency and can lead to surgery. And as Christian has mentioned, unfortunately, this condition can be fatal. C. difficile is a serious health threat. And not only do we believe this, but the CDC has designated it an urgent health threat. And to give you a sense of the magnitude, that in 2016, which is already old numbers and old data, it was responsible for $6.1 billion annually in the United States alone. It is the leading cause of diarrhea caused by antibiotics. And although we see numerous infections in individuals who've had antibiotics preceding, we also see a lot of patients who now have what's called community-acquired C. diff, which is no preceding antibiotics or risk factors in the 8 weeks before infections. And this is on the rise, and this is particularly on the rise in children. It accounts for about 75% of pediatric cases, which is really quite alarming, meaning we don't really know how to identify those individuals who are most at risk. In 2017, there were almost 500,000 infections, 224 hospitalizations, and 20,000 deaths. I'd like to emphasize here that these are extrapolated data, that we do not actually know how many infections or hospitalizations or deaths there are, because as Christian will tell you, the reporting system we currently have for C. diff only accounts for infections within hospitals that are required to track it. It does not include outpatient cases, and it does not include cases that are identified in nursing homes or long-term care facilities. So this is likely not only data from 2017, but also underestimates of what we actually see in the real world. As I said, we have seen a decrease in the number of cases of C. difficile, and this is showing the number of cases per 100,000 persons. And that's how we count things in medicine, per person years or persons. So as you can see, from 2015 down to 2020, we've seen a steady decrease in the number of overall cases of C. diff, which is really outstanding. Unfortunately, at the same time, we are seeing that recurrence rates of infection, so meaning people who have more than one episode of C. diff, these rates are going up. And we don't really have an explanation for why they were so high in 2015, seemed to dip a little bit in 2017 and 18, and now seem to be on the rise again. But again, highlighting the need for more research and more advocacy in this area. As I first mentioned, C. difficile is really difficult, and it's really difficult to make the diagnosis for several reasons. First of all, there's no universal test or even a universal testing protocol. For example, if you have strep throat, we know exactly how to identify that bacteria, and we have well-established testing parameters for designating a positive infection. This is not the case for C. difficile, and in fact, there are numerous tests available, and no two hospitals use the same tests or the same algorithm for making the diagnosis. It's also important to note that the available tests to identify the bacteria are not used to diagnose C. diff. So as I said, with strep throat, you test for the presence of the bacteria. In the case of C. diff, we don't routinely have the ability to test for the bacteria itself and are simply looking for markers that the bacteria was present. So we do not have access to culture and antibiotic sensitivity, which really improve the management and treatment and identification of an infection, where you say, this is the bacteria and these are the antibiotics or medications that we would like. And this is just not available for C. diff. We also know, and you'll hear today from some of our survivors, that there are many false negative tests and many false positive tests, making it very hard to understand who truly has C. diff and when do we need to treat and when do we need to escalate care. And finally, something that's really important for all of us to be aware of and really share with the people we know, and why it's so important to get involved with Peggy, Lillis, and other advocacy groups, is that not all providers know when to test for C. diff, and many patients go undiagnosed for far too long. This is a lot of medical information, and I don't expect anybody to come home and come away from this and know all of the details. But I just wanted to give you a sense when I said there are numerous tests for C. diff. This is a table showing all of the tests. And what you can see here is the different methodologies, but also their sensitivity. So how likely are the tests to pick up the infection? And here I've highlighted in yellow that the toxin enzyme immunoassays, which is one of our very common tests, is very useful when it's positive, meaning the specificity is 91 to 100%. However, but its ability to detect that is very low at only 51 to 63%. So we're really working with the deck stacked against us when we try to make a diagnosis. And you can see, looking at these numbers, why understanding when C. diff is likely, when to test, and how to interpret the results is really a key part of the world we live in. I want to move on to spend a few minutes talking about approaches for treating C. diff. And I really like this figure that I found just this week when I was looking up new studies on C. diff. And what it really did was break down the different modalities for treating C. diff and new methods that we should be thinking about to target this difficult bacteria. So you could think of doing direct killing. You could modulate your microbiome. You could modulate your immune system, or you could work on neutralizing the toxins, making those toxins A and B, which cause the severe disease, ineffective. So as you can see, we can get pretty granular with this, and you can see that the direct killing of the bacteria includes antibiotics as well as newer phage-based therapies. For microbiome manipulation or modulation, we have FMT and probiotics and defined mixtures or consortia, as well as newer treatments including antibodies and cytokine-directed therapies. Unfortunately, the ones with the stars are the only therapies that are widely available for our patients today. So we really have a number of different targets that we need to be exploring to understand how to get this devastating infection under control. And I'm going to spend the next few minutes talking about the available treatments to give you an overview. This is a nice review by Sahil Kahana at Mayo Clinic. And in this review, he identified the three main treatments for C. difficile that include antibiotics. And I'd like to highlight that this is not the granular details of how much and how often and how long, because that's really going to be decided by your clinician. But our primary antibiotics available for treating C. diff include our newest player on the block, fidaxomicin, also known by the brand name Difficid, which is a macrolide, and it is really a great choice for many of our patients. It's only twice a day and taken for 10 days and can be used as a first-line therapy for C. diff or recurrent C. diff. Our old standards include vancomycin and metronidazole, which are also available to treat infections. It is important to note that historically metronidazole was the first treatment. Sometimes this antibiotic is known as Flagyl, and this is actually not an approved therapy for C. difficile at this time, but historically was one of the first-line treatments. Now more often we use vancomycin and fidaxomicin unless dictated otherwise. The other important note here is that we should always stop the antibiotic that the patient was taking before developing the C. diff, if that is at all possible. Some of our patients won't be on antibiotics, but again, if you know that you've been taking an antibiotic and that might be causing your C. diff symptoms, then we'll try to get you off of it as quickly as possible. So as I mentioned, C. difficile is difficult, and there are high rates of antibiotic failure, leading to high rates of recurrence, estimated to be about 20 to 35%. And as you all know, antibiotics kill the bad bacteria, but they also kill the healthy bacteria and do not restore a healthy microbiome. Antibiotics used in the wrong setting or ineffectively can lead to antibiotic resistance. They can be quite expensive. And as I mentioned, the dosing can be quite intensive, up to 4 times a day for patients. Some patients don't tolerate certain antibiotics. And unfortunately, although it falls into a different class of treatments, probiotics do not prevent recurrence and cannot mitigate C. diff disease, unfortunately. Many of you are familiar with FMT, or fecal microbiota transplant, and there have been numerous studies since the last 20 years showing that FMT is highly effective and seems to be safe for the vast majority of patients with recurrent, refractory, or severe C. diff. I chose to just highlight one more recent article from 2020. This was part of our national registry, which include 20 sites and 259 participants. We hope to be publishing our newer data in the next few months, which will include 1,000 participants. And this included 8% pediatric patients with a range of disease severity. And what we found is that individuals who had C. diff had a 90% cure at 30 days, which is really, really outstanding. However, due to some regulatory challenges that FMT and stool banks are facing right now, we're not sure how long this treatment is going to remain available for our patients. And one of the things that we are engaging with at the Peggy Lillis Foundation is the regulatory bodies, including the FDA, to try to make sure that this life-saving treatment remains available for our patients. There are also some newer microbiota-based therapies, and here I've listed them with their brand name as well as the, quote, generic name. And just to give you a sense of how these medications work, I first want to highlight that these are not for the treatment of severe or fulminant C. diff. This treatment, known as Rebiota, is a fecal microbiota product similar to FMT that you would obtain from a stool bank. It is given as an enema. It is nice because there's no bowel prep or fasting, and it has a very similar safety profile to fecal microbiota transplantation. The big concerns here are that it does not seem to be as effective as we would like it to be, with response rates in the low 70% compared to almost 60% of placebo at 60 weeks. I also have a concern with it in that it's not yet available for kids. And as you can see, it costs $10,000 per unit. So we are really excited that these types of products are available, but still you can see these are not a one-size-fits-all solution. We also have Vowist, which is microbiota spores. And these are not used, again, for severe C. diff. These are to prevent a recurrence. So they will not necessarily help patients who have an active infection. This is a nice preparation in that it's oral capsules, which is much more easy to manage than an enema for most of our patients. It does require a fasting period of 8 hours and a bowel prep, which can be really difficult, especially if you're already having diarrhea or have just gotten over C. diff. There are some mild to moderate complaints. Again, no pediatric data, but the concern here is the cost, and many insurance companies won't cover it. Wholesale, $17,500, and out-of-pocket costs can be nothing, but all the way up to almost $10,000. So again, very excited to have more options on the horizon and available for our patients, but we don't yet have a cure for all of our patients. And this is a nice study showing the efficacy of SER-109, this newer therapy, which showed that the risk of recurrence in patients who got this was only 12% compared to individuals who had received placebo. So this does seem to be highly effective at reducing the risk of recurrence in our patients. I'd also like to highlight another class of treatments. This is an antibody treatment. This goes by the brand name Zinplava, or generic bezlotoxumab. And what it is it's an antibody. So it's a naturally occurring protein, and this protein binds to and neutralizes the C. diff toxin B, which is the big culprit for the symptoms. And this medication is used to reduce the risk of recurrence. So again, not useful for active infection, not useful for severe or fulminant C. diff, but may help those individuals who really just can't seem to break this vicious cycle of C. diff, antibiotics, C. diff. It's a one-time dose given IV while on antibiotics. There are some adverse events, and it is not appropriate medication for all patients. As you can see, some patients with pre-existing heart disease did experience heart failure. So again, it's not a perfect solution, but it is an option for many of our patients. It is approved for pediatrics, which makes me very happy, and is approved for adults as well, and has a wholesale cost of almost $5,000. In a study comparing bezlotuximab, we found that it had an 80% initial cure with a sustained cure of 64%. We're not sure that it works as well in pediatrics. In a study looking at 107 children who received this antibody treatment compared to placebo, there were low rates of recurrence in both groups. So we're not really sure if it's as effective in children, but it does seem to be safe and it may be helpful. Hard to make a lot of conclusions based on the small study size. So this is another treatment that is becoming increasingly available for patients who have recurrent C. diff. So I want to close because there's a lot of other great speakers tonight, but I just wanted to highlight a few take-home points. So first, diagnosing C. diff is not always straightforward. In fact, it's most often very muddy and very unclear. Recognizing when to test is essential. Antibiotics are a first-line treatment, but failure is common with high rates of recurrence. FMT has an effective rate of 80 to 90%. There are newer microbial therapeutics and antibody treatments available for recurrent C. diff, but not severe or fulminant. And much more research, education, and advocacy is important, as well as reporting of C. diff. And I just want to highlight the incredible work being done by the Peggy Lillis Foundation, which is the congressional proposal for a new Peggy Lillis C. difficile Inclusion Act, which was brought to Congress this year with efforts to make C. diff reportable, not just in hospitals, but in all locations, so that we can truly understand the burden of this disease and how to best put it out of our lives forever. And with that, I'd like to thank you all.
Thank you so much, Stacy. I really appreciated that. That was quite thorough. So before I introduce our next speaker, I just want to talk a little bit about the cost of these treatments. So I feel a couple of different ways about it. One is that when we're talking about a lot of other diseases, we can see costs that go into the tens of thousands of dollars. Most chronic diseases that's applicable to, most biologics that's applicable to, and patient advocacy organizations, sometimes in partnership with the companies and with concerned citizens, have fought for those to be covered. We are fighting for those to be covered by insurance, by Medicare, by Medicaid. So you know, that's where we're going. We want no one to go out of pocket for thousands of dollars. In the meantime, I do want to note that both Ferring and Nestle Health Science have very excellent patient assistance programs, and you can find access to them on our website at cdiff.org. If you have trouble paying for it, please contact us. We have worked with these companies to make sure that no one gets left behind for a difficulty with paying for their treatments. So, so that's that. We look for a day when all of these treatments are covered and they're accessible to everyone. So, and we're fighting for that. So our next speaker is, I was joking that we work with a lot of Kevins, and he is my current favorite Kevin, but don't tell the other Kevins. So Dr. Kevin Garey is a true leader and an innovator in C. diff. He is the Robert L. Bobbitt Endowed Professor of Drug Discovery at the University of Houston College of Pharmacy. He runs the Garey Lab, which performs collaborative translational research and training on the microbiome, C. diff, and other hospital-acquired or antimicrobial-resistant pathogens. Last year, we presented Dr. Garey with our Innovator Award for developing the C. diff 32, a questionnaire that helps those developing new treatments to assess not only their clinical impact, but also their impact on a patient's quality of life. So please join me in welcoming Kevin Garey, who is going to present on new and upcoming treatments.
Thank you, Christian. That joke is getting old already, so feel free to not use it anymore. And hello from Houston, Texas. It's great to be here with everyone. So Stacy was great and essentially gave a lovely overview of how you treat C. diff. And so my role here is to essentially take that to the next level, show you some really cool science that's coming out of the C. diff treatment world, and hopefully provide some helpful tips that you can use yourself or inform others. So if you think about how you treat C. diff, and Stacy teed this up really nicely, it's a microbiome disease, and so we have to get those healthy gut microbes back. It is a infectious disease, so we need an antibiotic to kill it. And if there's some way we could augment our immune system, so our immune system either kills the bug or kills the toxins that the bug produces, well, that would be really great as well. And so we can take those therapeutic goals, the things we want to do with C. diff, and actually turn them into drugs. And so these were introduced by Stacy already to restore our microbiome. Well, you could give somebody else's feces, a fecal microbiota transplantation, which many of you are very familiar with. Well, there's now second generation that Stacy introduced Rebiota and Voust, and I'll take a deeper dive into that. My formatting's all screwed up, at least on my screen, but the drugs we have are metronidazole, no more, because it's no longer recommended. Vancomycin, which many persons will have a love and hate relationship with, because when you were taking it, it was effective at stopping the diarrhea, but as soon as you stopped, your C. diff came back. There's a better drug, fidaxomicin. I'll show you some cool research on that. And the bezlotoxumab is your immune booster, and so I'm going to show you some neat stuff in that as well. Okay, so this is the best of the U.S. guidelines is the IDSA SHEA guidelines. There's another one, AGA, but I'll pick the IDSA SHEA as my favorite. And they have got with the program and said, use fidaxomicin first line in terms of everybody. And that's because it's way, way better at preventing C. diff recurrence than vancomycin is. And I want to take that fidaxomicin and show you some neat stuff. Go to the left and you'll see that kind of neat red and green image. And if you ever wondered what the enemy looks like, what C. diff looks like, that's that red. And you can stare at it with hatred and think it's evil, and it is. And that's the spore. And that green thing around it, that's ironic enough fidaxomicin. So fidaxomicin not only doesn't kill your microbes in the gut as much as others do, but it also kind of puts this ring around C. diff spores. So if they ever germinate, fidaxomicin is right there to kill it, which is a really neat property of the drug. Go to that middle slide, and C. diff was never, fidaxomicin was never meant to try to treat patients with multiple recurrences of C. diff. It really should be used first line. And so in some patients, and especially if you're using it first line in second, third, fourth recurrence, you'll fail that 10-day course. So there's a really neat study that says, well, instead of just taking it twice a day for 10 days, do that for 5 days, twice a day for 5 days, but then every other day for the next 20 days, giving you 25 total days of therapy. And the thought is those spores, that ring that you see on the picture, they stick around for a long time. So if you just kind of kept fidaxomicin around, it could either kill it if it's around or bind any spores that are around and kill it when it germinates. And so if you've tried fidaxomicin already and you get C. diff again, the word to remember is extend. Tell your provider, I've heard about this extend thing. Can we try that using fidaxomicin for 25 days? Christian can guide you, but I'm going to give you all the links of how to get the payments of these things down. So there's a nice coupon by Merck to bring your copay down for what is still an expensive drug, fidaxomicin. Okay, so bezlotoxumab is something called adjunctive. Adjunctive means you still need an antibiotic, but this is nice to have around. In this case, bezlotoxumab is nice to have around because it prevents recurrence, which is really neat. So let me show you some data here. So bezlotoxumab is given by an IV infusion. So you'll have to go into some sort of infusion center, and then it's a one-time only dose. So that's convenient. And then in this case, it forms a ring around your colon. How about that for crazy? And so the C. diff that lives in your gut produces disease by producing these toxins called toxin A and toxin B. And this B toxin leaves the gut and goes into your systemic circulation and causes disease. When that happens, this Bezlo antibodies is there to neutralize it, to blow it up. And the antibody then enters into the colon to even help blow up some more of that toxin B. So the way it works is really fascinating. You do need an IV, so it's probably not for your first round of C. diff, but for the second or recurrent, like, yeah, give me an IV one time, no problem. And then the half-life is 20 days. And then if you're talking to any good pharmacist, they will immediately divide that number by 3, 60 days, and they'll say, holy moly, that's around in your body for probably 3 months or more. So that one-time infusion protects you from C. diff recurrence for 3 months or more, which makes it a really interesting drug. I would just say that this is the clinical data I helped produce from Houston and all around the country that shows that it protects you for a nice long time, and by about it halves your risk of recurrence. Usually given an outpatient, almost always, and then you have to go see an infusion clinic, and that's the Merck Access program for Zimplava. You probably won't need that as a patient because your providers will generally set you up for an infusion clinic, and they will know where to find that URL. But if they don't, make sure you show it to them. Okay, fecal microbiota transplantation was addressed in the 2019 guidelines, and they said use it after the second or subsequent recurrences. Now, when I say feces, hopefully everyone goes, "Oh my gosh, that's the craziest therapy the world's ever seen." And this is what everybody thinks. How can this be a safe, effective product, and now a moneymaker because of the indicated products that are out there? And so, since the time of the first fecal microbiota transplantation, which was really a spouse providing a fecal sample to their husband, in this case, by a blender, we've come a long ways, baby. And I want to kind of go take a deeper dive into that. So there's now a second generation of FMT is here. It's called live biotherapeutic products. That's the general name for it. As opposed to being individual specialists that know how to do this, this is now an FDA product. And there's a definition for what an LBP is, a non-vaccine biologic that contains live organisms that are applicable for the treatment of disease in humans. And in C. diff, it's another adjunctive therapy, and it's designed to prevent C. diff recurrence. Very similar to bezlotoxumab. You're still going to need an antibiotic, but this is one that if you have a very disrupted microbiome, this is the one you're going to be reaching for. So there's two. They have lots of names, as Stacy introduced too. RBX2660, also known as Rebiota, SEER109, now known as VOWST. And from a patient perspective, it's the biggest consideration is, can you tolerate the oral? And if you can, that's 4 capsules once daily. Or would you prefer a one-time enema given one time and you're done? The one's the enema, the Rebiota. Another one's an oral, and that's SEER109. Now, what is the difference between these LPBs and FMT? Well, they're both from feces, so they both start from there. But listen to this, like it's not anybody that's going to be donating these feces. For RBL, it has to from a single stool donor. So actually, the enema you get, you will actually know where it came from, or the company will. That person has to be healthy. They'll have tested that stool twice, and they'll test it again. And they will make sure that that person is healthy. Now, for the capsules, you can picture this. It's somebody young. They are skinny. They have no diseases whatsoever. Their physical history is perfect. Their family history is perfect. And you're slowly getting the thought of, this sounds like Ronaldo or Brandy Chastain or something like Tom Cruise. Like maybe I want a piece of that too. So these guys are really, really healthy when they donate. And so because it's a FDA product, the screening is great, the sample screening is great, and it goes through FDA quality good manufacturing. A lot of things go into this to make this a much, much safer product than FMTs that were actually very safe to begin with as well. And so if you think about it, like, well, what are the side effects that you would expect when you're putting a whole bunch of organisms into the person's gut? And if you've ever ordered the large salad from Salada, which is about 5 pounds of lettuce, at the end of that feed, your stomach will be grumbling. You'll be a little uncomfortable. You might have some gas. And that's because you just fed the microbes in your gut a ton of food. And so think of it in reverse. In this case, you're dropping in a ton of new microbes that now have a smorgasbord of stuff to eat. And so the exact same types of adverse events will happen. Some GI discomfort, some gas, maybe a little bit of diarrhea. That's what you're going to expect. Probiotics don't do that as much, but that's probably because there's just not many microbes there. And the greatest risk with FMT has been very rare, but when they did the screening, they missed the an important bug that actually causes infection. And so that's much, much, much more less likely with these LPBs that go through such a big, rigorous screening process. This is data that Stacy's already shown, just showing that in this case, the up is really good, and that's the RBX2660 or the CR109 on the left and the right, and the brownish oranges are bad. And so you get much better response rates with both CR109 and RBX2660. This is a lot of graphs, but I want to walk you through something because this is really fascinating. So take your eye over to that CR109 on the left, and there's two figures there. The top one is placebo, and the second one is CR109. So this is a patient's quality of life. And you can see the light blue bars are all going up, and the dark blue bars are all going down. That first one is your total quality of life, and all the other subsequent ones are domains: physical, mental, social. So you really have to pay attention to that first one. Where you see when you give somebody, the up, I'm sorry, is if you don't have a recurrence, which I didn't explain yet, the light blue. And the darker blue is if you do have a recurrence. So that recurrence drops your quality of life. And that's a big, big, big driver with patient quality of life. So if you're on a placebo and you don't have recurrence, your quality of life goes up. But if you're on a placebo and you have a recurrence, your quality of life goes way down. So that's what that's trying to say. Okay, I didn't do that great, but I think I'm okay. Now go down to the CR109 because here's the amazing part of all of this. So once again, CR109, you can see when the light blue goes up, they don't have a recurrence. Their quality of life goes way, way up. But now look at the darker blue. When these patients have recurrence, and there's fewer of them, but their quality of life doesn't go down. So maybe that microbe transplantation is really good at preventing recurrence, but it actually even improves the quality of life of patients. That's what that's trying to illustrate. Now going over to RBX2660, in this particular case, the red is the drug, the RBX2660, and the blue is the placebo. And then the next one over, if you go to the A bar, that's baseline when they're all the same. But even by week 1, 7 days later, the quality of life of patients given RBX2660 goes up and goes up even further after week 4. So it improves your quality of life and improves your quality of life quite quickly. And I think all the C. diff survivors in the audience today who've had an FMT will probably be shaking their heads up and down. Yeah, I did feel a lot better after I got that FMT. It's remarkable. Really, really cool science. Okay, so they're here. LPBs are really exciting new therapies. RBX2660 is the enema, CR109 is the oral, and there are your two patient assistance programs URLs. Maybe the best is yet to come. There's lots out there. There's a next generation fidaxomicin, a bezapolstat. This is a distinct mechanism of action with some microbiome work. It actually looks like it has maybe better anti-recurrence properties than fidaxomicin, or at least just as good. And VE303 is another, I'm going to call it a third generation FMT. This one is just the bugs. There's no feces involved. They've just grown and learned how to grow this consortium of bacteria that are able to prevent C. diff recurrence. So keep your eyes open. Bezapolstat is not enrolling yet, so keep your eyes on clinicaltrials.gov. VE303 is currently enrolling. If you're in the Houston area, just contact me and I can help get you enrolled. If you're not in Houston, there's actually a virtual site that you can log into and then get access to the clinical trial. Okay, so it's not every day that we get all these brand new medications that are specifically designed to prevent C. diff recurrence. So when you are seeing a provider, don't say, what can you do for me? Really ask the question, what can you do for me to prevent recurrent C. diff? And there's lots out there. So if the provider says, what are you talking about? Contact Christian, because he can get you in hold of a lot of people who know the state of the art. So Christian, thanks again for the opportunity to present here today. It's always great working with you and learning from you as well.
Thank you so much, Kevin. And we're very excited. You know, when we started this in 2010, we got fidaxomicin, and then it was like 11 years before we got Rebiota. And now there's just so much that is being done, and it's very exciting. And in addition to the links that Kevin shared, you can also go to our website. We have information about the VE303 trial and the other trial, which Kevin mentioned is not yet enrolling, but as soon as it is, we will have that information as well. And it's worth, if you're somebody out there who has not found the right cure for C. diff, you're still battling recurrences, there are other clinical trials on our website. You can go to the In Your State part of our website and see what's available around you. You can contact us because, you know, these are big trials that Kevin's talking about. There are smaller investigator-led ones that are always happening. And so hopefully we can help you find the right thing for you. And as always, Kevin is brilliant, and that was really excellent. Switching focus a little bit here to talk about, you know, the social economic impacts of C. diff and looking at almost the reverse. So I'm actually really excited. I'm going to admit to you all that I read this paper 3 weeks ago, and I reached out to the next speaker immediately and said, would you please do our town hall? Because I think this is so important. So I'm really delighted to have Dr. Jacinda Abdul-Mutakabbir. She's an assistant professor of clinical pharmacy at the Skaggs School of Pharmacy and Pharmaceutical Sciences and the Division of the Black Diaspora and African American Studies. She's going to share her and her colleagues' research into the impact of socio and economic vulnerabilities on CDI outcomes. So welcome, Jam, as she invited me to call her.
As Christian stated, my name is Jacinda Abdul-Mutakabbir, but I go by Jam, like peanut butter and jam. So feel free to use it. So this research was done in collaboration with my research group at Loma Linda University in Loma Linda, California. I was actually at Loma Linda until January of 2023 when I was recruited to the University of California, San Diego. So just taking you all to Loma Linda. The Loma Linda University Medical Center is a teaching hospital and a tertiary center. And the hospital is located in Loma Linda, California. And it primarily serves San Bernardino County residents. So just some quick facts on San Bernardino County and just San Bernardino County's demographics. So 70% of San Bernardino is populated by racially and ethnically minoritized individuals. Hereafter, called REM group, so Black, African American, or in Hispanic Latino. So to give you all just a little bit more perspective, San Bernardino County is a bit, or is located in the Inland Empire, which is vastly cheaper than living in Los Angeles or San Diego or some of those areas that are more expensive for folks to live in Southern California. So we do see a mass exodus from those areas, especially with gentrification, which is why it's majorly populated by REM individuals. So REM residents report the lowest median income and are more likely to reside in areas of lower socioeconomic status. Of the major counties in Southern California, San Bernardino County has the highest rate of REM individuals diagnosed with chronic comorbidities, that being hypertension or high blood pressure, diabetes, and so on. And also in San Bernardino County, REM residents are more likely to be uninsured and less likely to have access to a primary care physician. So when we think about background on CDI, and I don't have to spend a ton of time here because you all are experts and you know exactly what the burden is. But when we consider C. diff, it's of course associated with prolonged hospitalizations and mortality. However, recent data indicates that patients who are uninsured or underinsured are more likely to be diagnosed with CDI. Furthermore, when we think about folks that have pre-existing diseases, that being like high blood pressure or diabetes, they've also been shown to contribute to poor CDI outcomes. So previously, my group, we went ahead and we did a research project on racial disparities in C. diff. Actually, Doctors Kahn and Garey really set this up for me because we were actually looking at the new therapies that were on the market for C. diff, and we wanted to just kind of, deduce, were we treating folks appropriately? But as we were doing this research, we started to realize that the bulk of the patients that were actually even included in the study period were racially and ethnically minoritized. So that really pushed us to say, oh, wait, it's a disparity here. Let's look at this and try to figure out why it exists. So this was a retrospective cohort study designed to look at racial differences in C. diff. So what we did was we actually separated the patients into two different cohorts or two different groups. So we had a racially and ethnically minoritized cohort, and then we had a cohort of non-racially and ethnically minoritized patients. And what we saw was that 62% of our cohort were racially and ethnically minoritized, and then 38% were non-racially and ethnically minoritized. Well, in our racially and ethnically minoritized cohorts, the individuals were younger. They were more likely to be underinsured. That means that they had Medi-Cal or Medicaid or governmental issued insurance or no private insurance. They were more likely to have higher rates of diabetes, and they were more likely to have higher rates of chronic kidney disease, and they had higher rates of severe presentation of C. diff. So then what we continued to see was that our racially and ethnically minoritized individuals were shown to be at a 1.6 increased odds of severe or fulminant CDI when compared to the non-racially and ethnically minoritized patients. And we saw that that 10% of this was actually mediated by pre-existing chronic kidney disease. So ultimately, what we saw was the existence of another disease state, so like chronic kidney disease, which is oftentimes, mediated by being diagnosed with diabetes and that diabetes progressing due to less access to healthcare. Well, that chronic kidney disease is contributing to C. diff. So we can see there that it's definitely a problem. So then we sent this paper in. Thankfully, it was received by the journal. It was published. But one thing that we got from reviewers that really stuck with me was that race is a construct, right? So race doesn't necessarily explain why it is that these patients have C. diff. So then at this point, I had to say, well, now we have to expand our disparity lens. So social determinants of health inequities have been hypothesized to contribute to poorer C. diff outcomes. And there's a true gap in the literature that investigates the confluence of being a part of a racially and ethnically minoritized groups, and then what we see in terms of social determinants of health and their contribution to C. diff outcomes. So the Centers for Disease Control and Prevention, the CDC, they have the Social Vulnerability Index, also known as the SVI, and it's a surrogate measurement that's often used to describe neighborhood level social determinants of health. And they do this based on 4 themes. So the 4 themes of the CDC SVI include socioeconomic status, which will be abbreviated to SES, housing characteristics, abbreviated to HNC, racial and ethnicity status, abbreviated to RIM, and then housing and transportation status, abbreviated to HNT. So the objective of this study that I'm going to discuss with you all was to utilize those 4 themes of the CDC SBI to determine the impact, or to at least use the surrogate to try to elucidate the impact of social determinants of health on initial CDI severity and then all-cause mortality outcomes. So for the study subject inclusion, so we had adult patients that were admitted to the LUMC between January 1st, 2020 to June 30, 2021. So essentially what we did was we took the inclusion criteria from our previous study that was published that looked exclusively at racial and ethnic disparities, and we used that same inclusion criteria for our study here. So we wanted to just apply the social vulnerability lens to what we saw with the racial and ethnic disparities. So the inclusion criteria were patients that resided outside of San Bernardino County or Riverside County, which really comprised the Inland Empire area. And then patients that had addresses that did not have an identifiable census tract, because the social vulnerability index tool actually uses census tracts or zip codes to identify the level of vulnerability. So if the patients did not have that, then we did not include them into the study. And then the clinical outcomes that we investigated, or at least characterized, were initial severe CDI, initial fulminant CDI, and then all-cause mortality. So when we look at just the overall vulnerability and just the incorporation of the SBI tool, so just a breakdown of what it is that this shows us. So it shows the socioeconomic status, and comprising that is folks that live below the 150% poverty line, those folks that are unemployed, housing cost burden, no high school diploma, no health insurance. Looking at the household characteristics, it includes folks that are age 65 and older, 17 and younger, civilian with disabilities, so on. Racial and ethnic minority status include these racially and ethnically minoritized groups. And then housing type and transportation actually considers the crowding of the house, whether the folks have transportation or a vehicle to get to actually get to healthcare measures, group quarters. So really looking at just the transmission of the disease and how that may impact these individuals. So then we went ahead and we looked at the, so when using the social vulnerability index anyway, the CDC actually stratifies, or the index stratifies based upon vulnerability level where these individuals lie. So low vulnerability has a 0 to 0.299 score, 0.25 to 0.499 is low to medium vulnerability. Medium high vulnerability is 0.5 to 0.499, and then high vulnerability is 0.5 to 1. So for purposes and ease in aggregating the data and actually being able to describe it in a meaningful way, we actually combine the low vulnerability and low medium vulnerability groups, and then we combined the medium high and then the high vulnerability group. So when we look at the results for the study, looking at study demographics, we had 219 patients from the previous study that were screened. 206 were actually included for data analysis. We excluded 13 individuals for the reasons listed here. Either they resided in a county outside of our area, or we had folks that didn't have an identifiable census tract. So when we look at the individuals in the groups of low vulnerability, which is abbreviated to LV, we had 14 that in low vulnerability, 27 in low medium, so about 41 individuals there. And then when we consider the groups of medium high, so high vulnerability and high vulnerability, which comprise our high vulnerability group, we can see that we had 165 individuals cumulatively, and it will not, in high vulnerability, will be abbreviated to HV moving forward. So when we look at our study demographics, or just, overall what the study makeup was for the 206 patients, age median, about 62 years old, 46 to 76 being our range. And then the female sex, we had the bulk of our patients identified as female, so 51.5%. The bulk of our participants, or the individuals, our includees, were from San Bernardino County. And then when we looked at our race and ethnicity, as previously described with our first study, the bulk of these folks were a part of a racially and ethnically minoritized group. So we have 40.3% that identified as Hispanic Latino, and then 13.6% that identified as Black, and then about 2.9% that identified as white. So when we look at just the overall social vulnerability characterization, so these are the overall numbers, not considering like the CDI outcomes and so on. So when we look at we had 206 includees in the study in its entirety. When we look at those folks in the that had high vulnerability scoring, or when we look at socioeconomic status, 75% had a high vulnerability score. When we look at household characteristics, 71.4%, which makes sense, right? Because our median age was about 62. 71.4% had a high vulnerability scoring. When we look at racial and ethnic minority status, we planned for this because we knew that the bulk of our participants identified as racially and ethnically minoritized. 93.7% were in a high vulnerability, received a high vulnerability score. And then we looked at housing type and transportation. 64.6% of the individuals included in this study had a high vulnerability score in this area. When we look at what we saw in terms of the severity of initial C. diff, well, the bulk of the individuals here had either severe C. diff or fulminant C. diff. When we look at those individuals with severe C. diff, we can see 81.2% had a high vulnerability score for overall SVI. When we look at those individuals that have fulminant C. diff, we can see that 78.9% had a high vulnerability score. When we consider those individuals or all-cause mortality, it occurred in 20 individuals, so 9.7% of the folks that were included in the study. 18 out of 20, 90% of those individuals had a high vulnerability score. So when we look at the social vulnerability themes, so like the deconstruction of those 4 specific themes, and we apply that to initial severe CDI, we can see that the frequency of initial severe CDI was 15 times greater in the SVI theme for racially and ethnically minoritized, 3 times greater in the SVI theme of SES and housing characteristics, and then 2 times greater in the SVI theme of housing and transportation. When we look at the SVI themes and initial fulminant CDI, we can see that the initial presentation of the fulminant CDI was 37 times greater in the SVI theme of racially and ethnically minoritized, 3 times greater in the SVI theme of socioeconomic status and household characteristics, and then 2 times greater for the SVI theme of housing and transportation. When we look at all-cause mortality, what we can see is that the all-cause mortality was 9 times greater in the SVI theme of REM and socioeconomic status, 4 times greater in the SVI theme of household characteristics, and 1.5 times greater in the SVI theme of housing type and transportation. So ultimately, what we see is that patients residing in areas of high vulnerability with susceptible household compositions may face socioeconomic obstacles that affect CDI severity. High vulnerability scores across SES, H&C, REM status, and H&T are correlated with increased CDI severity and mortality rates. A limitation of this study, of course, is that it's single center, so only at Loma Linda, retrospective in its design, and it was not necessarily detected or powered to detect differences in mortality. An additional limitation was the low number of low vulnerability patients, but that is because Loma Linda is located in a highly disparaged area, so we're more likely to get those folks that are most disparaged. Nonetheless, we do believe that this data will provide a basis for interventions designed to address C. diff disparities at Loma Linda. However, we do understand that further research in this area is warranted and needed. So I'd like to acknowledge my research group, and I'm very thankful to them. And here are my references here, and I will stop the show. Thank you.
Thank you so much, Jacinda. That was a lot of really important information. And I think I'm very grateful for you and your collaborators in putting this forward, because I'm someone who grew up on welfare, on Medicaid. And so despite having, landed in a kind of white collar life, we always want to center people who are particularly vulnerable around this disease. So your research is going to be critically important in helping us make those kind of arguments. So thank you so much. And I'm now very happy to introduce Carol Raye. Carol is a C. diff survivor in Boise, Idaho. After attending our 2020 virtual C. diff summit, she contacted us to learn how she could get involved. And over the past 4 years, Carol has been just an incredible volunteer and is now a member of our board of directors. She is the chair of our Advocates Council and a vital member of our peer support program. Carol's intelligence, passion, and empathy never fail to impress me. So please join me in welcoming Carol Raye, who's going to talk about her experience as an advocate and peer support volunteer.
Thank you, Christian. That was really sweet. So, as he said, I am a C. diff survivor. In the spring of 2011, I had outpatient surgery for a broken wrist. And that following winter, my dentist prescribed clindamycin, and within about a month, I was extremely ill. At the time, I lived alone, and it was really hard to take care of myself. I could find very little information about C. diff. It was a lonely and frightening time with very little help. After 2 rounds of Flagyl, I was feeling even sicker. Then came multiple courses of vancomycin, which did not cure the CDI. It was 6 months before I was cleared for an FMT via colonoscopy. I have an extreme anaphylactic allergic reaction to cow's milk protein, so I had to find a donor on my own whose stool would be safe. The infection was finally cured by FMT, and thankfully I have not had a recurrence. As Christian said, I jumped on board in 2020 and have been very active and really enjoyed the work. Last March, I had the pleasure of speaking at Tech Lab's annual sales meeting in Las Vegas. They make the C. diff quick check complete tests. The patient experience is something that the salespeople really don't have access to, and it was a very interesting conversation. And they picked up a lot of what they would not know about our patient view. I feel lucky to have been able to attend 3 lobby days and help my political leaders understand C. diff, at least beginning to get them to understand. I've gained great friendships through volunteering for PLF, a lot who are like family. And then 2 years ago, we developed the peer support program, and I've met some awesome people doing peer support work too, and made some very lasting friendships. It's not always easy because it takes me back to how much fear I felt when I was sick, but it's always rewarding to know that I can help other people who are suffering and afraid like I was. For example, one lady requested support because her elderly mother had a C. diff infection. She'd had 3 antibiotic treatments that had failed and was recommended to have an FMT, but they kept running into roadblocks and poor communication with the providers. They lived in a remote town 6 hours from the doctor, so it wasn't easy for them. And the daughter felt so alone and overwhelmed and didn't know what to do to help her mother, and she needed guidance. She needed help navigating insurance. She had trouble with supply issues and understanding the process. Finally, when Rebyota had been approved, her 78-year-old mother was finally able to be cured. It was a wonderful thing when she called me and told me that. Another really interesting peer support request was from a medical student who had a lot of pre-existing medical issues and was a C. diff survivor. The Peggy Lillis Foundation Facebook page was one of her saving graces. It connected her with another C. diff patient her age, and they were able to support each other and lift each other up. She contacted the Peer Support Network, interestingly, because she was speaking to her medical school class about her experience and wanted some coaching. I hope by giving you a brief idea of what I went through, speaking to you today, that you will not only see what a C. diff sufferer goes through, but also how rewarding it is to be an advocate and to support others once you feel well enough to give back. And I know we're running a little late, so I'm going to turn it back over to Christian.
Oh, I thought you were going to take a little longer than that.
Well,
that's okay.
I thought I'd try to catch up on time.
I appreciate that. Well, thank you so much. And I'm going to talk a little bit about policy now, and then we're going to get to the Q&A. So if you have any questions, please pop them in there. And Carl, can you help me get my slides up? Okay, it wasn't Carl's fault, it was my fault. So I just want to speak with you guys briefly about policy, laws, regulations, and things that impact C. diff and some of what we've been working on. So here we go. So currently there are a number of policies at the federal level that are mostly related to reporting and surveillance of C. diff. So hospitals are mandated by their participation in Medicare and Medicaid to report to the CDC's National Healthcare Safety Network. Some states also require reporting from other healthcare facilities, though it varies greatly by state. Nursing homes are encouraged but not required to report C. diff infections. And similarly, antibiotic stewardship programs, which we haven't really touched on a lot tonight, but basically a program that helps determine whether or not antibiotics are being overprescribed. Those are encouraged but also not required. And so one of the things that have been implemented in the last few years is that the Centers for Medicare and Medicaid, if you have they have a hospital-acquired condition reduction program. And so if your hospital falls into the lowest quintile of hospitals in terms of how many C. diff cases you have, they will deduct 1% from your Medicare and Medicaid reimbursement rates. So that's a little difficult for hospitals, but the good news is that from 2022 to 2023, hospital onset C. diff has dropped by 13%. And so that reflects the infection control improvements that people have been doing to make sure that they don't get this ding from Medicare. So back in 2018, Peggy Lillis Foundation launched the first and to this day the only lobby day for C. diff. So you can see some pictures here from that and the following years. Our advocates, as Carol mentioned, go and talk to their congresspeople about C. diff, really educate them. Cannot tell you how many times I've been in a room where a congressional staff member or a legislator says that they had never heard of C. diff, or were the first people to ever come and talk to them about C. diff. And PLF has also supported legislation that isn't specific to C. diff, but would help people in terms of battling the infection. So there's the PASTOR Act, which is currently being considered in Congress, and we do hope it will pass before the end of this Congress. And the goal there is to incentivize more antibiotic development because antibiotics are incredibly expensive to develop and very hard to make money off of. So there's also the Help Co-Pays Act, which would provide, sort of cap the amount that you could be expected to pay for a copay. And then the Safe Step Act. And this is important because a lot of what both Stacy and Kevin and even Jacinda presented were really things about step therapy. So, you're first given vancomycin usually because it's the cheapest drug. If that doesn't work, you're given fidaxomicin because that's more expensive. If you have another recurrence, you end up getting probably more fidaxomicin or more vancomycin. And so at this point, you've been through 3 and 4 treatment rounds before you're offered something like Raye or Vowst. And we would like to see that moved up to help people suffer less and for a shorter duration of time. And the Safe Step Act is one of the ways that we could potentially do that. So Stacy mentioned this. I have been really touched and excited to have the Peggy Lillis CDI Inclusion Act introduced into this Congress. We have always wanted more reporting. As Stacy mentioned, community acquired cases, so basically people who get C. diff and go to their local doctor or go to a city MD type place. None of those cases of C. diff are reported. And also, as Stacy noted, like kids, 70% of kids have community acquired C. diff. So I feel like we could potentially be missing the forest from the trees. Like, why is this happening? And as long as those infections don't have to be reported, there's a very good chance that we really can't do that kind of research. So I'm very pleased that my Congresswoman Yvette Clarke introduced this bill in August of 2024. Unlikely to make it through this Congress for a whole host of reasons, but it's, you have to start somewhere. So to support the bill, we hosted a congressional briefing in September of this year. It featured the wonderful Dr. Stacy Kahn, one of our board members, Marion Webb, who's another C. diff survivor, and Dr. Sean Popinski, whose last name I didn't put on the slide. And so what we're currently looking to do is to find a Republican co-sponsor. Yvette Clarke is a Democrat. We're looking to find a Republican co-sponsor so that we can reintroduce the bill in the next Congress. So that would be, starting in January of 2025. So if you're listening to this and you're a Republican congressperson and you're willing to talk to them about this, get in touch with us. And the last thing I want to touch on before I talk a little bit about what's ahead and then we take questions is that we've been pretty active in regulatory advocacy since 2022. Several of our advocates testified at the FDA Advisory Committee meeting on RBX 2660, which is now Raye. That was the first ever approved live microbiome therapeutic for recurrent C. diff. This helped pave the way for the FDA's approval of the first capsule live microbiome therapeutic, which is CR109, now known as Vowst. And more recently, we met with the FDA Center for Biologics Evaluation and Research to urge them to maintain access to the traditional FMT that Stacy and Kevin spoke about for pediatric patients and those who have fulminant disease. And the reason this is important, despite the incredible progress of having 2 new approved treatments, is that neither of those treatments are approved for use in children. So anyone under the 18 is not eligible for those drugs. And also when people have severe and fulminant disease, those products are not indicated for that. So we hope with more research, eventually we will have an FDA approved product. But for right now, people have severe fulminant disease. And to make that clear, that means that people have an extremely high fever. They might be going into organ failure. They're going into septic shock. And we have seen with FMT that, in those cases, having a fecal transplant, sometimes it might take more than one, has brought people back from being that severely ill. So far what we've won is that FDA will continue to allow this for people with severe and fulminant disease, including pediatrics, through the end of 2024. And we're hopeful that they will permit it past that. So what's ahead for us is, as I mentioned, we want the bipartisan reintroduction of the Peggy Lillis CDI Inclusion Act. We want to maintain access to that traditional FMT for patients that are not eligible for the FDA-approved products. Kevin and Stacy touched on the clinical guidelines. Patients have not been very involved in the review and discussion of clinical guidelines around C. diff, and that's something that we are working with the professional associations to change. And then we are currently planning for 2025 and 2026. So we are hoping to have additional priorities around advocacy once that plan is complete. And we'll be releasing that plan for everyone in January, February. So I hope this was helpful to give just a kind of lay of the land. We are going to move to questions. If you have additional questions, please put them in. We're going to bring all of our speakers back, or all the speakers who are still with us, and try to answer the questions you have. Hello, Carol. Hello, Stacy.
Feel like it's Hollywood Squares.
Yeah, I know. I like it to be Paul Lind if it's Hollywood Squares. Okay, we have Jacinda coming back as well. So the first question we had is, what is the guidance about when to test? And what I think this person is asking is, you've had C. diff once, you suspect it might be back. Like, what is the point? I think this is probably a question for you, Stacy. When would you advise somebody to, advocate for themselves or kind of insist on being tested again?
Yeah, it's a great question. Well, with the high recurrence rates and the difficulty in making a diagnosis because the tests we have are not perfect, I think that patients who've experienced C. diff before and feel like the symptoms have come back, particularly after finishing a course of antibiotics or another microbiota-based therapy or a C. diff therapy, we should definitely think about it. A lot of individuals who experience C. diff can also have what's called a post-infectious irritable bowel syndrome, or IBS, which can feel a bit like C. diff with crampiness and urgency and loose stools. So making a diagnosis and knowing if more antibiotics are needed is really important, or if we need to treat their conditions or look for other things. In general, we don't recommend testing while on antibiotics or testing for cure, meaning that we don't recommend that after you finish your antibiotics, you say, let me just get a test. The tests are actually only accurate if they're done on unformed stool, and we say generally 3 or more loose stools a day is an indication. But patients often know when it's back, and so I often prep my patients by saying, like, you're going on a taper, you're going to be done, let's have the test ready, have it printed in your hand with the container and the vancomycin or fidaxomicin prescription ready to go, so that once the sample's dropped off, you can get on the antibiotics immediately and wait for those results to come in, so we don't waste precious days of you feeling not well while we're waiting for test results.
So this person has clarified that they actually meant an initial case, which I think is interesting. Which I think brings us into the kind of the diagnosis conundrum. I don't know, Kevin, if you have thoughts there as well, or Stacy, if it changes for you when it's an initial case.
We recommend patients who have 3 or more loose stools, who it's persistent, associated with belly pain, certainly if there's blood, mucus, fever, if they're being worked up for other infectious diarrheas, that it's reasonable to test. We generally don't test children under 1 year of age because of rates of colonization, but really we recommend it for anybody who has the symptoms, and particularly in individuals who have been on antibiotics, been hospitalized, had cancer, had a transplant, or have inflammatory bowel disease, feeding tubes, things like that. So really anybody who has the symptoms should be tested sooner rather than later, because this is not a stomach bug that's just going to go away on its own.
In the hospital, it's hard to do, but it's more intuitively easy. Have you been in the hospital for a while? Do you have a high-risk antibiotic? And then C. diff is the #1 cause of infectious diarrhea in hospitalized patients. So in that case, you still take a look. Are they on laxatives, something else that might cause diarrhea, but you generally test. On the outpatient, it is more difficult. But you do start off with, have you had a high risk antibiotic in the recent past? Clindamycin comes into play, augmentin, antibiotics in general. Now, even with that, antibiotics can cause diarrhea by themselves without being C. diff, and there's lots and lots of other reasons why you have diarrhea. Some tougher diagnosis, but then after that, Stacy's spot on with everything she's saying. Just stay vigilant.
And I would say, just as a follow-up, I think it's absolutely right. You're hearing my pediatric viewpoint, which is that most of our pediatric patients haven't been on antibiotics. So we tend to have a very low threshold because we're not always seeing those classical risk factors that are seen in the adult population. So it does make a difference.
Yeah, I mean, I think part of the part of the challenge that we have here is that people don't know, they're not aware of C. diff, and so they don't think to ask about it. And, I know Kevin and Stacy and will agree with me that, people who've trained in medicine or pharmacy, 20, 30, 40 years ago, like this was a disease of the elderly. And so oftentimes, if you're a young person who presents, doctors might think of everything else before C. diff. So that's why it's important for people to know it exists and to think about, I've had antibiotics, so I've had that, I've had this risk factor. So the next question we have, and I think it's the last one, so we'll all be able to finish more or less on time, is they ask, I've had recurrent C. diff 2 cases. Do you believe FMT will ever be available for prevention, not just immediately following a case of C. diff and antibiotic treatment?
I can probably start that one. So, and the question might be like, why is it that you want to continue the antibiotic until a few days before the FMT? It would be another way to rephrase that question. And the reason why, as soon as the antibiotic that you're treating, let's say vancomycin, leaves your body, that day is your absolutely highest risk day. And then for approximately the first 1 month, you're quite high risk. And then the second month, you're still at high risk, but less than the first, and et cetera, et cetera. So there certainly would be benefit to, if you haven't got it after a few days. But the reason why we really try to time that correctly is your highest risk is immediately after you stop that antibiotic, because your own body starts to naturally regrow the microbiome, if you were able to, for the persons with first or second recurrences.
So we actually did get 2 more. So one is, my C. diff infection was July of this year. When do recurrences usually occur? I mean, my understanding is usually like a recurrence would be within like 6 to 12 weeks, right?
Yeah. I don't want to hug the mic, but I'll just provide my input too. So you're absolutely right, Kristen. You nailed it. It's 3 months. After 3 months, you're sort of in the clear. And then you're at risk again when you get another high risk antibiotic. But I'll just kind of restate what I said last time too. But your highest risk is immediately after you stop that antibiotics. And so when you think, if you want to just kind of put some timers on it, your first month is when you're at highest risk. Second month, still risk, but less. Third month, you're kind of breathing easier. And by the end of that third month, you can really walk around as if you're at the same risk as all of us that haven't had that high risk antibiotic before.
Yeah, and then the next question is kind of almost connected to this one, which they ask, how do they build up their microbiome? They're tired of wasting money on probiotics not supported by science. Do we have any new research supporting any diet or probiotics?
I'm happy to tackle that one. It's one of the things I spend a lot of my time talking about. I'm sure everybody in this group can speak to how do you get over it. What I tell my patients is really the most important thing is to restore that microbiome. So not to take antibiotics unless they're absolutely required. That doesn't mean you shouldn't take them if you need them. Let's be clear, but you shouldn't take them if you don't need them, and take them for the shortest amount of time and the least strong antibiotic possible, which is what we always want people to be doing. But the thing I tell my patients and I tell my pediatric patients is you should eat the rainbow. And what we mean by that is you should eat healthy foods, fruits and vegetables that help restore the microbiome to its baseline. We recommend avoiding processed foods, junk foods, fast foods. We really want a clean diet. Does that mean you can never have a slice of pizza? No, it means that we really want you to be working on getting those healthy microbes. And we know that the healthier your diet, the healthier your microbes. And then just common sense, we know that C. diff doesn't respond to a lot of different things that try to kill it, like hand sanitizer and alcohol, wipes and things like that don't kill C. diff. So really good hand washing and just awareness and taking care of your health.
We did get two more, and then I think that's probably all we're going to have time for. So one person asks, advice for preventing C. diff in the future in the long term. Oh, and they popped it up there, so we can all see it.
First and foremost, in adults, I'll start with there. When you are being given an antibiotic by your clinician, ask the question, do I really need it? That goes an awful long way to preventing it. That's the biggest risk factor. And there's a lot you can do to prevent that from happening. Is there something alternatively you can do? That should be your first question. Then, in my opinion, Stacy, you nailed it. The high fiber diet, the stuff that's a little hard to swallow because you got to chew it a little bit, the high fiber stuff, that's what's really good. And if you can couple that, do I really need that antibiotic with a really good high fiber diet? You're doing a lot of your own good for you.
Yeah, and I think it's worth mentioning that we have an issue in this country with the overprescription of antibiotics where they're not medically necessary, and part of that is I think doctors being cautious because they're not quite certain if it's bacterial or viral, but we also have patients asking for them because they've been trained to do that. It's not like they just woke up one day. So I do agree. I mean, I always ask, do I really need this? And I've had antibiotics, I think, twice in the past 20 years. And then last question. What is the standard prophylaxis dosage for vancomycin or diff while being treated with an antibiotic? I'm a C. diff survivor having had an FMT. I guess they're asking like if they needed an antibiotic, what is the prophylactic dosage?
So I'd say that this is a question that's going to depend on your provider, and that some doctors feel very strongly about giving it, some don't. There is not a standard, I would be very cautious to say. Generally, for patients who've had multiply recurrent C. diff and have had an FMT, I use a low dose of vancomycin for a few days while they're on the antibiotic, because the risk of recurrence is just so high for other reasons. So vancomycin once or twice a day for the duration of the antibiotics, and really try to get you off it as soon as possible. But this is off book. This is not something that necessarily all of my colleagues would recommend. But again, I see, some of the more refractory cases. So I tend to be more cautious. I don't know if Kevin has a different opinion.
I'm not a prophylaxis fan. So the IDSA guidelines don't recommend it because that same disruption to the microbiome that the high-risk antibiotic causes, vancomycin is one of those high-risk antibiotics. And as soon as you stop the prophylaxis, you created a microbiome that's very susceptible to C. diff. And that's why it's controversial. But Stacy, I do with you. In those refractory cases that you're super worried about, I don't really want to do it, but this is the person that I might consider it for.
Absolutely. It's not for everybody. It's really for those cases or those individuals who also have other risk factors for C. diff besides the antibiotic, like a feeding tube or a history of cancer, things like that, where they're actively being treated for other conditions. Then you really want to be extra cautious. But I agree, it's not something we need to do standard.
Yeah.
And I feel like something, because that was the last question, and before I thank you all and let you go, I think, One of the things that we really try to help people do, and I think that has come across in folks' presentations, from Carol's to the response to these questions, to even, Jam talking about, people who are particularly vulnerable because of their socioeconomic position, is to the extent that people can educate themselves and advocate for themselves. And I always say, if you're able to, if you have a doctor's appointment that you're a little bit worried about, bring somebody with you. It's very hard. And I wonder if you two as clinicians would even agree with me that if you're being told something by a doctor that, is worrying, like sometimes you kind of go a little foggy. And so having somebody with you who can try to write stuff down and think about questions to ask can be helpful. But yeah, I think that's all we have. And we're a little bit over, so I'm going to release you. I want to thank Dr. Stacy Kahn, Dr. Kevin Garey, Carol Raye, and Jam. That's what I'm going to call you from now on. I love that. Really excellent presentations. Thank you guys so much for doing this. We are so grateful to Nestle for sponsoring it. And I guess we'll see you all next year for our next State of C. diff virtual town hall. Have a good night, everybody.